Hello, and thanks for having me speak today. My name is Kent Bashford. I'm a glaucoma specialist that works out of Fort Collins, Colorado, in a large group, and I'd like to talk about when natural outflow isn't enough, what's next. My financial disclosures are here. My objectives today are to review the options for subconjunctival stents and shunts with emphasis on the Zen. I'd like to start with a patient G. This is a longtime patient of mine, 77-year-old white female with severe glaucoma. She had a Zen 3.5 years ago placed in her right eye, and she's done extremely well with this. Pressure's 12 today. She is on azopt twice a day. But we've noticed that the left eye is getting worse. Pachymetries are 541 and 525. Historical high hasn't been that high, 28 in the right, 21 in the left. She has asthma. She's allergic to bromonidine. So currently her visual acuities are very good, 20/25 in the right, 20/20 in the left. Pressure in that left eye is 19, and she's on Vyzulta and azopt. There's her central cornea thickness again. Surgery, she has had cataract surgery with an iStent inject 5 years ago. She was actually in the iStent inject trial. Here's her OCT, shows average RNFL thickness of 63 in the right eye and 58 in the left. We see that she's got thinning in both eyes. We look at her visual fields, we see a worsening over the last few years. Those are last 4 or 5 years of visual fields, and we can see that they were pretty straight across there. In the last 3 or 4 fields, we're just starting to lose the battle medically and with the iStent inject. So start to consider our surgical options. Angle surgery, she already has an iStent inject. We could consider a GAT, a hydrus, or a KDB goniotomy. We could think about a Zen gel stent, trabeculectomy, or tube shunt. What would you do? Ask that question, think through this a little bit. As I thought through it, I thought GAT, hydrus, KDB, while they're low risk, we've already kind of been that route. Pressures in general after those procedures are in the 16 to 18 range. And I feel like she might need a little lower. Her pressures have gotten worse in the 15, 16 to 19 range. So I really feel like I need a little more than what one of those would give us. Zen has low risk, medium risk, there is a bleb, and the IOP lowering is in the 13 to 16 ranges where a lot of the studies end up with Zen. Trabeculectomy tube, they have medium to higher risk, probably, and the IOP lowering is in the 12 to 16 range. We decided to go with a Zen. She had done so well in her other eye with her Zen that we decided to go ahead and move forward with that. Of course, it's a surgical implant indicated for refractory glaucoma, directs fluid from the anterior chamber through the sclera and under the conjunctiva. It does create a bleb. Has a 45 micron inner lumen that creates enough resistance so there's a low risk of hypotony. It enables continuous flow from day one to keep the conjunctiva and the sclera separate. Here's a picture of the injector and the stent as it comes out of the needle. Here's a Zen implanted. There's a gonioscopy view and then an external view from a slit lamp. They're on the right. The bottom view is a UBM view of a Zen as it goes from the anterior chamber through the sclera and underneath the conjunctiva. Here's a series of pictures that kind of shows the anticipated way that we would use Zen after its approval, which was an ab-internal approach through the anterior chamber, around the trabecular meshwork, through the sclera and underneath the conjunctiva, without opening the conjunctiva, using an injection of mitomycin, that kind of a thing. Zen FDA trial was published in 2017. It had 65 patients in it. The medicated IOP started in the 20 to 35 range is what was required as an inclusion criteria. And they had to have either failed max meds or failed prior filter or CPC. At 1 year, we see the lowering effect of Zen. The baselines was about 25.1 millimeters of mercury, and at 12 months, the average was 15.9. It's about a 9.1 drop in IOP over a year. Meds, baseline, we started at 3.5, and at 12 months, they were at 1.7 on average. I looked at my first 45 Zen patients from 2017 to January 2019. My interocular pressure started about 21.9 and ended up at 15.5. We started at 2.8 meds and ended up on an average of 1 medication. So very similar to the trial, I started with a little lower interocular pressure than we did in the FDA trial. Zen versus Trab. This study was published a few years ago. Of course, they'd had Zen available to them in Europe much earlier than we did here in the US. This compared 185 Zens to 169 Trabs, and the results are very similar. Zen 24 millimeters of mercury down to 13 on no meds, and the trabeculectomy group started in that 24 range and ended in around the 13 range. Needling rates were a little higher for Zen, they're 43% and 31% for Trab, but really no significant difference between Zen and trabeculectomy. The Zen surgical technique has changed quite a bit, and many people have tried a lot of different things with it. In the FDA trial, I was on that trial. We did ab internal with an open conj. We had to open the conj because we had to use an FDA approved method to apply mitomycin C, which was mitosol at that time. So we had to use the sponges, but we knew that as soon as it got approved, we were all going to use it with a closed conjunctiva ab internal. Did that for a number of months. Then the idea started to come up of how to do it ab external. This was off-label. Used a closed conjunctiva. Often these would end up intratenons, and that's been something that's been very interesting with the closed conjunctival techniques, is whether they're sub, intra, or supratenons, and the effect on pressure and how effective they are has been an issue. Now, many people are doing open conjunctival ab external, either placing them superior tenons, but more commonly, I think subtenons is more common now. So here's a picture of these different methods, ways of doing it. Again, in the pivotal trial, we went ab internal, we opened the conj, applied our mitomycin with sponges, and then closed the conj over the top of the stent. I was very excited once it got approved to start using an injection of mitomycin and go ab internal, place the device underneath the conjunctiva, and get out very quickly and efficiently with no conjunctival incision or needle tract other than the mitomycin, which we could put far away from our surgery site. Then the idea was brought up to go ab external, close conj and place the needle through the conjunctiva, through the sclera and into the anterior chamber, and making that the only incision really needed for the procedure. Some were doing paracentesis, some were not, and using, again, mitomycin injected. This was a very fast procedure, and it was very elegant and beautiful. I found that after doing it this way, that some of these were where I had some erosions. I had a higher scarring rate. A little plug would form on the end of the Zen that would make the surgery fail. So we started to look for other ways to do it, and really came to an ab external open conj technique. Open a conj much like a trab opening. I still inject my mitomycin, and then place the stent and close the conj over the top, much like you would a trabeculectomy incision. Mitomycin C application, of course, sponges. Trial, we used 2 sponges, 0.2 milligrams per milliliter. With a injection, now There's a lot of different ways to do this. My current technique is to go 0.4 milligrams per milliliter. I inject about 0.05 cc's into the eye. Sometimes I'll go up to 0.1. That gives me about 20 to 40 micrograms. Most people do great with 40 micrograms. I have a number of little old white ladies that I don't want to go too high. They're pretty thin conch, so on those I'll use 0.05. I've heard people using up to 70 micrograms of mitomycin C though. My current technique, I code this as a 66183. Officially, it's an insertion of an anterior segment aqueous drainage device without extraocular reservoir, but with an external approach. So my technique is I inject the mitomycin first, 0.4 milligrams per milliliter, and again 0.05 or 0.07, somewhere in that range, superiorly. I try and get these supranasally. I open the conjunctiva at the limbus, measure about 2.5 millimeters back, and I insert the stent in an ab-external fashion. I then confirm placement with a goniomer. If I can't see it, sometimes I can see it and I can adjust that with a little tying forceps, exactly the depth. And then I'll close the conj with an 8/0 Vicryl. Post-op, if I can observe them, if their pressure is fairly low, 6 to 14 or so, their blood is elevated, all is well. We just kind of let them run through a steroid course of 4 to 6 weeks and normal antibiotics. Always think about and consider intervention if the IOP increases. Might needle these. Sometimes we'll surgically open them. If there's no bleb, if there's a flat anterior chamber, if there's choroidals, we kind of look at things. Although I have found, for the most part, even with choroidals, hypotony, I wait these out, the pressure usually comes up. I have not had to do any major intervention because of hypotony in a number of years of doing Zen. Complication, bleb scarring again. Needling, studies have shown in the 30 to 40% range. I think with an open conj sub-tenons that my rate is much lower than that. I would think in the 10 to 15. I haven't measured it. I'll needle early. Again, I think one of the keys is to make sure that it's sub-tenons against the sclera. I do that by opening the conj. Hypotony, again, I have not had a hypotony that's caused a major problem. I've had choroidals. I've had choroidals last a while, but they usually resolve on their own, and the hypotony usually goes away, resolved on its own. Complications, conjunctival erosion. This was more of an issue with closed conjunctival techniques I found. It's really important to watch the angle of placement, that as you place that needle that you're going as parallel to the sclera as you can. Subtenons I think helps. I've heard of some people actually placing a suture over the Zen to hold it against the sclera and to help force an angle from occurring of that Zen of kind of popping up. I've had a couple, and again mostly with the ab-external way closed conj, where the Zen has tented up the conjunctiva, and it's made me nervous. Thought that over the years that pressure might eventually erode through. And so on 2 of these now, I've taken them to the YAG laser, put a mandelkorn lens or a suture lysis lens on that conjunctiva, and just one or 2 laser zaps will break off that Zen, and it'll take that pressure off. Just 1 to 2 shots, 1.5, 1 to 1.9 millijoules, all it takes to do that. So just to revisit our patient G, she underwent an ab-external glaucoma drainage device with a Zen gel shunt. Just had her surgery 2 weeks ago or so, and I saw her 1 week post-op. Her pressure was 14 in that left eye on no meds. She has an elevated bleb, so we'll see how she heals. Hopefully this eye will do as well as her first eye. Interesting, another very similar idea is the PreserFlow stent by Santen. We're waiting for its approval. By the time we show this video, it may be approved. It's made of sieves, a very biostable thermoplastic. It's placed ab-external with an open conj, 8.5 millimeters in total length. and it's got a little wingspan there, a little wing there to help hold it in place. Here's a picture of a PreserFlow under the eye with a bleb and what that might look like. The pivotal PreserFlow versus TRAB trial. We're starting to see the data from this. It was presented at the American Glaucoma Society. It's in press in the Journal of Ophthalmology, waiting for its release. But at 1 year, if we look at the PreserFlow, it's in the green. The pressure went from a 21, the baseline pressure before surgery, to a 14.2 millimeters of mercury, and medications went from 3.1 to 0.6 meds in the PreserFlow. It's interesting to compare this to the TRAB. These are the best TRAB results I've ever seen, and I think it's because in Focus, when they recruited for this trial, they got outstanding trabeculectomy surgeons because they had tremendous results in this, and I was not in this trial. But it'll be interesting to see how we use PreserFlow, how it compares to Zen after it's available to all of us. Thank you very much for your time. Hope everybody has a great day. Thanks.